Sarah and Aaron have CLABSI. CLABSI stands for Central Line Associated Bloodstream Infection. So the introduction, a central line associated bloodstream infection is defined as a laboratory confirmed bloodstream infection not related to an infection at another site that develops within 48 hours of central line placement. Of all the healthcare associated infections, CLABSI are associated with a high cost burden, accounting for approximately $46,000 per case. Most cases are preventable with proper aseptic technique, surveillance, and management strategies. Etiology, based on the National Healthcare Safety Network data from 2006 to October of 2007, the order of selected pathogens associated with CLABSI are as follows: gram-positive organisms, coagulase negative staphylococci, enterococci, and Staphylococcus aureus are the most common, followed by gram-negatives, Klebsiella, Enterobacter, Pseudomonas, E. coli, and Acinetobacter, Candida species, and others. Tunneled hemodialysis catheters are prone to CRVSIs. Approximately 40 to 80% of CRVSIs are caused by gram-positive organisms. Coagulase negative staphylococci, Staphylococcus aureus, and Enterococcus are the most common organisms. Methicillin-resistant Staphylococcus is frequently seen. 20 to 30% of infections, CRVSIs, are caused by gram-negative organisms. Pathophysiology, central lines are two types. Tunneled catheters are implanted surgically by creating a subcutaneous tract before entering the vein into the internal jugular, subclavian, or femoral vein for long-term, weeks to months use, such as chemotherapy, hemodialysis, and then there's the non-tunneled catheters, more commonly used. They are temporary central venous catheters that are inserted percutaneously and account for most CLABSI. Within 7 to 10 days of central venous catheter placement, bacteria on the skin surface migrate along the external surface of the catheter from the skin exit site towards the intravascular space. Typically, tunneled catheters have a cuff that causes a fibrotic reaction around the catheter, creating a barrier of bacterial migration. The absence of a tunnel, a subcutaneous tract, places non-tunnel catheters at higher risk for CLABSI. CLABSI that occur beyond 10 days are usually caused by contamination of the hub, typically from a healthcare provider, contaminated hands, but rarely from a host, and often due to breach of standard aseptic precautions to access the hub. Less common mechanisms include hematogeneous seeding of bacteria from the contaminated infusite or another source. Host factors that increase the risk for CLABSI are chronic illness, which is hemodialysis, malignancies, gastrointestinal tract disorders, pulmonary hypertension, immune suppressed states, organ transplant, diabetes mellitus, malnutrition, TPN, extremes of age, loss of skin integrity, burns, and prolonged hospitalization before line insertion. The femoral central venous catheters are associated with the highest risk of CLABSI, followed by the internal jugular and subclavian catheters. Further, the catheter type, condition of insertion, emergent versus elective, use of full barrier precautions versus limited, catheter care, and skill of the operator also influence the risk of CLABSI.
Pseudomonas is commonly seen and associated with neutropenia, severe illness, or known prior colonization. Candida is associated with the following risk factors: femoral catheterization, TPN, prolonged administration of broad-spectrum antibiotics, hematologic malignancy, or solid organ or hematopoietic stem cell transplantation. Certain bacteria such as Staphylococci, Pseudomonas, and Candida produce extracellular polysaccharide, which favors increased virulence, adherence to catheter surface, and resistance to antimicrobial therapy.
Clinical manifestations vary depending on the severity of illnesses. Fever and chills are the most common manifestations but can be masked if the patient is immunocompromised or at extremes of an age where atypical presentations of sepsis occur, which leads to altered mental status, hypotension, lethargy, and fatigue. Exit site examination to look for signs of inflammation of tunneled catheters with inspection and palpation of the subcutaneous tract is important. Patients may report pain, swelling, or discharge from the exit site and redness surrounding the exit site along the subcutaneous tract when the exit site or tunnel infections are present. For long-term catheters, difficulty in drawing blood or poor flow are considered risk factors and manifestations of CLABSI. Duration of therapy. For patients with uncomplicated CRBSI, in the absence of risk factors for hematogenous spread and negative blood culture, 72 hours of catheter removal. Following approach for intravenous antimicrobial therapy is recommended. Number 1, S. aureus is 14 days in the absence of endocarditis. How do you say that?
Coagulase negative.
Coagulase negative
Staphylococci
is 7 days. Enterococci and gram-negative bacilli, 10 to 14 days, and candida, 14 days in the absence of retinitis.
Okay, so the treatment and management. When CLABSI is suspected, empiric therapy should be based on the most likely organism, host factors, and the overall clinical picture. While awaiting cultures, empiric treatment should be instituted promptly. In general, coverage for common gram-positive and gram-negative organisms is necessary. The local prevalence and antimicrobial susceptibility patterns is institutional antibiograms should be taken into account. The following are some considerations. So the first one is parenteral vancomycin. If methicillin-resistant staphylococci, so MRSA, is prevalent, otherwise, parental anti-staphylococcal penicillin or cephalosporins such as nafcillin or cefazolin would suffice. If MRSA isolates are exhibiting in a minimum inhibitory concentration of less than 2 milligrams per milliliter for vancomycin, or in the case of vancomycin resistance enterococci, daptomycin is the drug of choice. Number 2, the antibiotic choice for gram-negative coverage should be based on the risk of pseudomonal infection and local susceptibility patterns. If the risk of Pseudomonas is low, then a third-generation cephalosporin such as ceftriaxone is appropriate. In patients with critical illness or high risk for resistant organisms, a combination of beta-lactam and aminoglycoside is preferred. Cefpime or carbapenem with or without aminoglycoside. Agents against Pseudomonas are required in the setting of neutropenia, severe illness, or known prior colonization. Number 3, echinocandins are preferred agents for suspected candidemia if azole resistance or suspected non-albicans candida such as C. glabrata or C. cerevisiae. Otherwise, intravenous fluconazole would suffice. Antifungal therapy should be considered in the setting of femoral catheterization, TPN, prolonged administration of broad-spectrum antibiotics, hematologic malignancy, or solid organ or bone marrow transplant recipients. Once the antimicrobial susceptibility results are available, de-escalation to specific appropriate therapy is recommended. If blood cultures have no growth, the need for further empiric antibiotic treatment should be reassessed. If unexplained fever or sepsis persisted in a patient with short-term central venous or arterial catheter impaired peripheral venipuncture and catheter blood cultures have failed to identify CLABSI, the catheter should be removed and the tip should be sent for culture. All non-tunneled catheters causing CLABSI should be removed promptly, sometimes even before it is proven with the above criteria when clinical suspicion is high. Only for long-term catheters, salvage can be attempted in limited instances, such as there's two things. So the first one is uncomplicated CLABSI caused by organisms other than Staphylococcus aureus, Pseudomonas aeruginosa, Bacillus micrococcus species, proprion bacteria, fungi, or mycobacteria. And the second one is the patients with limited vascular access sites or the ones who are solely dependent on central access for survival. In the case of tunneled hemodialysis catheters, uncomplicated exit site infections can be treated with short-course topical or systemic antimicrobials. All tunnel infections will require catheter removal due to high risk of CLABSI. Additional indications for removal in CLABSI from hemodialysis access include, there's four things. The first one is persistent symptoms, which is more than 36 hours or severe sepsis, hemodynamic instability, so that's shock, and metastatic infections. The second one is blood cultures that remain positive more than 72 hours of appropriate antimicrobial therapy. The third one is difficult to clear organisms. The fourth one is reoccurrence of uncomplicated CLABSI when salvaged for difficult access.